When you talk about the blood supply is simple. It's simple. Arterial and venous, arterial and venous. If you talk about the venous, we have superior thyroid vein, middle thyroid vein, and then we have inferior thyroid vein. If you talk about arterial, we have the superior thyroid artery and the inferior thyroid artery. In some cases, yes, in some cases, 1 to 2% of cases, there may be a direct branch from aorta, and what is that known as? Thyroid ema. So, thyroidema or thyroidema, there are two terms for this. Thyroidema is a direct branch from aorta. Now, why I am discussing this arterial supply? Because I want to discuss some important anatomical relations. They are very, very, very important. Let us see them. So let us take this to be a thyroid. So we have common carotid. Giving rise to internal and external. This is common carotid artery. External will give one branch which is known as superior thyroid artery. Superior thyroid artery has two divisions. One will travel along the anterior border, yes, and one will travel along the posterior border. So this is how the things are. Now then you talk about the thyrocervical tongue, the thyrocervical trunk. So the thyrocervical trunk is giving rise to what? Inferior thyroid artery. Inferior thyroid artery, yes, at the level of the neck, it goes up at the level of the neck near the scalenus muscles. It takes a right angle. So this is inferior thyroid artery. It takes a right angle and then it goes behind the common carotid. So it is going behind the common carotid and then it comes out, yes, and then it will give again two branches. One is the superior branch and one is the inferior branch of inferior thyroid artery. Do you know inferior branch is not a single branch, but there are numerous branches coming out and draining this part. Yes. And one more important point is that this is the branch which is giving the supply to what? Parathyroids also. So one point is clear, that you cannot ligate the inferior thyroid away. You have to ligate it as close as to the gland. There are many students who have confused, sir, where to ligate superior, where to ligate inferior. Remember a rule in life. Mind your own business. Stay as close to the gland. You will never damage any structure. Like when we do cholecystectomy, laparoscopic cholecystectomy, you always have a fear of damaging the CBD. Like in my life, I have done somewhere around, not lying, I must have done around 5,000 lap choles. And maybe 1 or 2 cases of CBD injury will be there. But they happen just because it might be related with the Mirzi syndrome, etc. or no. So try to understand what is my idea of doing a lap cholecystectomy. My idea of doing lap cholecystectomy: dissect a posterior window first, stay away from the liver and hepatobiliary communications. Now you have only the gallbladder with you. You play with it, you damage it, but you will not damage any crucial structures. Similarly, don't locate the structures which might be injured. Stay away from them. If you talk about recurrent laryngeal nerve, there is a dictum, don't even go near that. Stay as close to the gland as possible. Remember that you are not injuring any structure other than the required structures which are to be ligated. You will never damage the recurrent laryngeal nerve also. Now try to see what is important relation here. Now from below, the recurrent laryngeal nerve is coming and it is now going posteriorly, and now it will be going and entering inside the what? Yes, it will be entering inside the larynx like this. Yes or no? So if you see, I'll just make one correction here. So this is like this. Okay. If you see, there is a small triangle here. Can you appreciate a small triangle? What is this triangle all about? On one side, this triangle is bound by common carotid. On one side, this triangle is bound by, yes, this is bound by your inferior thyroid. On one side, it is the recurrent laryngeal nerve. recurrent laryngeal nerve which is going like this, and this triangle is known as the famous Biard's triangle. Biard's triangle. What is the significance of Biard's triangle? No dissection is to be done here. So this is common carotid artery, inferior thyroid artery, and recurrent laryngeal nerve. Any dissection done in this part is going to damage the recurrent laryngeal nerve. So this anatomy is very important. So stay as close to the gland. Don't go near this anatomy. Don't go near the intersection of common carotid and inferior thyroid artery and start tracing for the recurrent laryngeal nerve. You will definitely damage it. Yes, you will definitely damage it. So the important point is ligation of superior thyroid pedicle plus inferior thyroid pedicle should be done as close to the gland. Inferior thyroid pedicle should be done close to the gland. One again very important thing is ligation of inferior thyroid pedicle should be done only after you locate the recurrent laryngeal nerve. If you don't locate, if you are not able to locate this, what is the most important landmark where you will definitely locate this? Yes, it is tubercle of Zucker-Candle. So remember, very important is, this has also been asked, most important landmark for recurrent laryngeal nerve. For recurrent laryngeal nerve, answer is tubercle of Zucker-Candle. Tubercle of Zucker-Candle. Zucker-Candle. This is the lateral most part of the gland. So it's a lateral most part of the gland, and you will always find recurrent laryngeal nerve in association with this tubercle. Next is, when I have initiated the talk on recurrent laryngeal nerve, I should be talking on recurrent laryngeal nerve. What is this concept of recurrent laryngeal nerve? Now there are two nerves, superior vagal branch and inferior vagal branch. Superior vagal branch will give you external and internal laryngeal nerve, and inferior vagal branch should go to the larynx. Yes, but what happens when it is going down? Yes, this is the scenario. This is the arch of aorta. So what happens? These branches, they take a U-turn. They take a U-turn around this. And they ascend up in the neck. Yes, they ascend up in the neck. And this is the reason why they are known as recurrent. So why they are known as recurrent? Because they go down and retrace their path up towards the neck. So on the left side, if you talk about, on the left side, they arch around the arch of aorta. On the right side, it is the right subclavian. Yes or no? So we have the right subclavian. This is the right subclavian artery, and this is the place where the right side branch will take a U-turn. Yes or no? So left takes around the arch of aorta, right branch takes around the right subclavian artery, and then they move up into the tracheoesophageal groove. Yes. Now try to understand one very important. What if they don't retrace the path? This is what is known as non-recurrent laryngeal nerve. What proportion of people do you see? 0.5 to 1% people are associated with non-recurrent laryngeal nerve, and this is a big challenge. You are not able to locate it. It might be a non-recurrent nerve, and you might damage it when removing the thyroid. So when can you see? So right-sided is more common than left. First of all, right-sided non-recurrence is more common than left. Point number one. The second is, what are the associations? It can be associated with, point number one, situs inversus. It could be associated with situs inversus. Point number one. Second is, it could be associated with Arteria Lusoria. Let us talk about this concept of Arteria Lusoria also. Arteria Lusoria is abnormal right subclavian artery. It is abnormal right subclavian artery. What is the abnormality in this? It's an abnormal right subclavian artery arising from, generally it is right, you can say innominate, which will give rise to right common carotid and this right subclavian. So this is arising from either the descending aorta, or it may be arising from left subclavian artery or left subclavian artery. Now what is the problem? I'll show this to you. The problem is very important. So this is the scenario that you are having. This is the right innominate, right, in this case it's a right common carotid artery. This is a left common carotid artery. Yes, left common carotid artery. And then this is a left subclavian artery. Now all of a sudden you realize, or body realizes, that there is nothing like right subclavian, and right subclavian is crying that no, I also want to go to my own places and that. So okay, body says now we don't have a scope, you can arise from the descending aorta. So this is aberrant right subclavian artery. Now you have made it. Now how it will go to the right side, because it's on the left side? Now you don't have any space left. Aorta is in the middle thoracic cage, and behind that you have posterior thoracic cavity, and even posterior thoracic cavity is occupied. Why? Because there is esophagus here. Yes or no? There is esophagus. So now the only path left for this is a path between, which is what? Prevertebral space. Yes, prevertebral space. So these are the thoracic vertebra and this is the prevertebral space. So what happens? This right subclavian artery decides to go by this prevertebral space. Can you see it is forming a ring like structure around the esophagus? Now what is the problem? This is what is known as Arteria Lusoria. Now try to understand why this is problem. This is a right subclavian, and being a right subclavian, it will always have pulsations. Yes or no? The pulsation of this vessel will always cause a posterior indentation. Can you see the pulsations? The pulsations will cause posterior indentation on the esophagus, and that is why it will cause intermittent dysphagia to this patient, and hence this is known as dysphagia lusoria. So what is the concept of dysphagia lusoria? It is the posterior indentation, yes, on the esophagus, This is what is known as, dysphagia lusoria. Are you getting all these things? This is very simple and straightforward. So either it could be it could be a case of situs inversus where you don't get to see recurrent laryngeal nerve, or in case of Arteria Lusoria. In miscellaneous, I'll discuss something about the superior thyroid artery and vein and their relation with the external laryngeal.
Subscribe and press the bell icon so you never miss an update from PrepLadder.